Hello, everyone. I am Professor Ong Teng Ek, a urologist from University of Malaya. Welcome to the section on localized urothelial cancer, the role of surgery, specifically on muscle-invasive bladder cancer and upper tract urothelial cancer. I'd like to thank the organizing committee for arranging the event and also for the chairperson that I always have the privilege to work with, Professor Maliza Saad, who always give energy to the whole venture. Bladder cancer, of course, is an important problem of the world. This is the latest global can statistics. It ranked number 9 in incidence, and for mortality, it ranks number 13. And comparing the incidence in the male from our part of the world, which is Southeast Asia, it is have a lower incidence compared to the Western world like Europe. And similarly for female, we do have a lower incidence compared to many other parts of the developed world. And back to home in Malaysia, we do have the latest cancer registry here. And comparing the older registry and the newer registry, in the older registry, the bladder cancer rank number 10 in the older registry for male. It's not in the top 10 in the latest cancer registry. For this particular talk, the surgery involved focuses on patient with stage 2 and stage 3A or up to B. Yeah, those are the area or the stages of disease where radical surgery is involved. Here is an illustration on a radical cystectomy. In male, it's called cystoprostatectomy because the prostate is to be removed in the same setting. And for female, it's slightly more complicated because it will involve removing the bladder and anterior centration, where the uterus, ovary, and the anterior wall of the vagina are removed at the same time. Of course, surgical removal for muscle-invasive bladder cancer is a gold standard. Yeah, the organ removed is as illustrated together with a lymph node dissection, which is an important part of the whole operation. Approaches, there are many types of approach, depend on the preference of the patient, the surgeon, and the institution who perform the operation. The open surgery, robotic, and other minimally invasive approaches, but they are all of comparable oncological and functional outcome. Lymph node dissection is an important thing. Yep, is to be recommended in all surgery of radical cystectomy. So there's of course the argument of between standard lymph node dissection or an extended template lymph node dissection. This question is answered in a very recent publication by the SWOG S1011 trial. This was published in 2024 in the New England Journal of Medicine by Steve Lanner and his group. Standard versus extended lymph node dissection in muscle-invasive bladder cancer. Yeah. Well, the outcome of this study showed that there was no advantage of the extended lymph node or extended lymph node dissection, versus standard kind of lymph node dissection in terms of disease-free survival and overall survival. So the clinical implication of this study is that standard lymph node dissection involving the external, internal iliac, and obturator lymph nodes is adequate and is sufficient for most patients with localized muscle invasive bladder cancer, and we do not need to go to extended level of lymph node dissection. So, and of standard lymph node dissection also adds to the morbidity to the survival and did not improve the overall survival of the patient. So, of course, after the performance of the radical cystectomy, it will comes to urinary diversion. Yeah, there are many types of urinary diversion. The main group will be either conduit, autotopic neobladder, or continent cutaneous reservoir. They depend on the preference of the patient and the condition of the patient, and also the choice as discussed with the surgeon. So this method of urinary diversion would be decided in a kind of a shared decision making. The characteristics of this urinary diversion are illustrated in the box as shown. So next, which method is better? Yeah. Well, of these many methods, there are pros and cons of the various urinary diversion, but the quality of lives are comparable, and there's no single method is definitely better than the others. Yeah, so it's all shared decision making between the surgeon and the patient. Over here, there are also other bladder preserving strategies that could be employed, other than radical surgery. Here, trimodality therapy, TMT, is often discussed and debated. The component of this method of management involve maximum TURBT, the resection of the bladder tumor, followed by chemoradiotherapy. Of course, this is very attractive, for the patient, because they do get to preserve the bladder. So in selected cases, it does offer equivalent 5-year survival to radical cystectomy RC, in selected patient, those with small unifocal tumor with no evidence of hydronephrosis. Those are very good candidates for trimodality therapy. As emphasized earlier, patient selection is important, on the tumor size, multifocality, renal function, and so on. And it's also important for follow-up for such a patient after TMT. While there are other advances in surgical technique, including MRI, guided radiotherapy, immunotherapy integration, we will see more of this, of course, in the future. There's also a very interesting news recently in May 2025 of the first human bladder transplant performed at UCLA, where a patient had bladder removed for malignancy and also have renal failure on dialysis, have a transplantation of the bladder and the kidney at the same time. As for the early result for this patient, it seems to be very encouraging. How about perioperative therapy, besides surgery? Well, this is a very important topic. I'm sure you will be highlighted many times in the UCAP event, in June. One of the most important publication would be this one in 2024 in the New England Journal of Medicine by Tom Poles and the investigator in the Niagara trial, showing the impact of perioperative durvalumab with neoadjuvant chemotherapy in operable bladder cancer. In this trial, the primary objective of event-free survival show the benefit of adding durvalumab to the standard of care, which is the cisplatin-based chemotherapy. And also, the endpoint of overall survival also demonstrated significance benefit of adding durvalumab. I think this is one of those finding that would change the management and recommendation for patient undergoing radical surgery. Now we will refer back to the guideline. So this is the latest guideline available from NCCN, March 25th, 2025. For stage 2, these are the most common group of patient with T2 disease, which is very suitable for radical surgery. So this is a box demonstrating the option available. If you look at the top part of this red box, the recommendation with category 1 recommendation will be neoadjuvant cisplatin-based combination chemotherapy or perioperative sandwich immunotherapy with neoadjuvant cisplatin-based combination chemotherapy followed by radical cystectomy. Well, so that is the standard of care at this moment with category 1 recommendation. The other options are for various other consideration. You can read that from the summary table here. And of course, after surgery, adjuvant therapy could be, instituted based on various factors and whether neoadjuvant treatment is given. Well, now if it comes to 3A, stage 3A, again, these are the various treatment options, but the one with the category 1 recommendation would be the one on top there, which is similar to stage 2 disease. And for stage 3B, so 3B, which is more advanced disease, downstaging with systemic therapy is recommended. So it's very important to work together with oncologists on this group of patients with advanced disease. And next we move to nephroureterectomy for patients with UTUC. So the surgical management of UTUC is, of course, radical nephroureterectomy, RNU, and it's a standard of care for high-risk UTUC, which involve en bloc dissection of kidney, ureter, and a covered bladder. And there are options open, lab, or robotic surgical approaches, but they are all offer similar oncological outcome. Lymphadenectomy is recommended. It offers survival benefit. Of course, the extent of lymph node dissection will be template based. Kidney sparing surgery could be considered in selected group of patients, those with low risk, small unifocal, low grade cancer. In that case, it could be considered, and also those with solitary kidney or CKD patients. The technique involves, of course, endoscopic ablation or segmental uretrectomy. So there's also a role of adjuvant intravesical chemotherapy to reduce recurrence, especially using mitomycin. Perioperative consideration, there are various neoadjuvant and adjuvant therapy that could be considered after discussion with the oncologist. This is the NCCN latest guideline on the management of UTUC, and this page shows the management plan for renal pelvis. Depending on the grade of the disease, most of the patient would undergo nephroureterectomy. The other endoscopic options are for selected group of patients. And for UTUC involving the ureter, depending on the location, various treatment options could be offered, but mainly nephroureterectomy is the mainstay of treatment. Whereas for adjuvant therapy, of course, depending on the pathological stage after surgery, those could be offered as well after a multidisciplinary team discussion. Just here we just give a few example of how we should, offer management or surgery or other treatment for the patient. Example A, 61 years old patient with a T2, N0, M0, unifocal small bladder tumor. Yeah, what option could we offer? Well, we could, of course, offer radical surgery, of course, with kind of perioperative therapy or trimodality therapy. The next case on UTUC, 70 years old patient with a single kidney and distal urethral tumor, yeah, way down, yeah. What are the options that we could offer? Well, we could offer radical nephroureterectomy. Yeah, that is not a problem, but of course, the patient will need, dialysis and renal support. Another option would be a distal uretrectomy with reimplantation of the ureter to the bladder. But the future direction, of course, would be personalized approach to the patient with precision medicine, and also redefining kind of a bladder preserving protocol. So in conclusion, yeah, surgery still at this time remain the cornerstone for the treatment of this group of patients. Yeah, muscle invasive bladder cancer, UTUC for non-metastatic patient. It involves also other modality as well that comes into the picture. So shared decision making is important, and also a multidisciplinary approach. So the future, of course, we will look for other precision medicine or new way, to manage this group of patients, and hopefully could reduce the morbidity and increase the quality of the life of the patient, and also prolong their survival. Thank you very much.